to change this fixed aortic stenosis. And this data which I'm going to show is in the Indian subsets. That is, the incidence of mortality which has happened in relation to TAVI, in relation to aortic stenosis, has gone up year on year. This is Indian data which was released in February 2020. That every year we are losing more and more patients to aortic stenosis, and this is something, every one of these deaths could have been prevented. And therefore, the need of the hour is to find why are we reluctant in India to suggest TAVI to our patients, whatever their age is. And I have sort of shortlisted up my presentation into these 6 categories. And we will address each of these. The first thing is the aging population. This is one major problem in our country, that my father is old, my grandfather is old. Should I get them to get this procedure? They are so frail, will they benefit? Now often the temptation is to say, let them be on medicines. They have lived their life, they are happy. But on medical management, they will not only have a short survival, but they will have a very, very torturing survival. They have all these episodes of breathlessness, they will have low blood pressure, they keep fainting, getting hurt. And what can you do? A patient who comes with severe aortic stenosis and low blood pressure, nothing, no medicine will increase their blood pressure. Now, for these patients earlier, surgical AVR was an option, but there is a lot of operative mortality when we talk about aortic valve replacement in the elderly. And this data shows us this, that normally the mortality with aortic valve replacement is around 3 to 4%. But in octogenarians, that mortality goes up to 3 times or 4 times that amount. From 3 to 4%, it goes up to 13%. And not to mention the morbidity, these patients do not tolerate these kind of procedures too well in terms of the operative scar. And this is where the problem comes up, that this is why people are a little afraid that, oh, should I undergo open heart surgery at the age of 75? Now, TAVR, as time has gone on, with age, this procedure was designed for old age people, and it started to push the limits. It's changing the perspectives that we are seeing our aortic stenosis patients with. The devices are evolving. Every company wants to get a valve which will have a better advantage over the last valve. Different strategies for simplifying the procedure. There is an entire subset of TAVI called minimalistic TAVI, which I will come to. Complications are going down. Even the indications are getting more and more wider for the TAVI procedure. Now, this is how we decide for every single patient. We have a heart team meeting where we decide all these things: how frail is the patient, what is their STA score, what is their Euro score, and these are the score categories. That is, a patient with a high risk for surgery or a prohibitive risk for surgery, meaning they have a 15 to 50% chance of a mortality on the surgery table. And all these studies which have been done show that in these categories of extreme risk versus high, intermediate and lower risk, the TAVI versus normal standard therapy, TAVI has fared much better in all these aspects: mortality, strokes, whereas in the high risk, intermediate risk and lower risk category, TAVI has fared equally to surgery. And this is what we are going to discuss very briefly over the next few slides. I don't want to show too many slides on data, but for TAVI was started in 2001 in the inoperable case. The first patient who underwent TAVI had a life expectancy of 1 day. And in that subset of prohibitive risk TAVI, these 2 trials showed that, look, rather than giving them medicines, do a TAVI. It's a low risk procedure and their survivals are significantly better. So there was a no-brainer. Prohibitive risk, definitely go ahead with the TAVI. But what about high risk? Again, 2 trials came up, Partner 1 and the US pivotal trial, and they showed that in the high risk category, TAVI was equivalent. It was not inferior in any way, whether it comes to death or strokes or other side effects. Now, this is the core valve trial, which also showed that although it was better, it just missed the superiority cutoff. The cutoff was 0.01 or less, and it just missed that superiority cutoff. That's how good this procedure is when you do a TAVR in a high risk patient. All the strokes, vascular complications, MACE rates, life-threatening bleedings are all less. The only thing that we will discuss is a complication of noteworthy difference is the pacemaker requirement. And then as people got more excited with this procedure, we went down to intermediate risks. Patients who don't have that higher risk, but yes, there are certain risks associated with these patients. And lo and behold, we found the same results that because TAVR had such low complications, things like deaths, strokes, again were equal to the surgical outcomes. Now this is to show that there are benefits and risks for both procedures. The risks which are higher in surgery are the bleeding, the acute kidney injury, and very high risk of atrial fibrillation, which is seen in as many as 1/4 of the patients. Whereas in TAVR, there are some vascular complications and the aortic regurgitation and pacemaker rates, which I will come to. So this was another trial called the SIR-TAVI trial, which showed similar outcomes, and it showed that the pacemaker rates were high. Now, these are the parallel outcomes in terms of complications we see all the trials. So, I'm not going to get into these complications in relation to every trial, but these are the risks and benefits in association with these two different kinds of options for our patients. Now, why is this next slide so important? Is because these three trials have completely given surgeons a big setback in terms of patients who are being offered TAVR. And these trials suddenly opened our eyes and said that look, any walk-in patient, whether the risk is high or low, TAVR can be an option for them. And this trial, the MOTION trial, showed that the primary endpoint of death and MI and stroke was similar in both the arms, TAVI equal to surgery. Earlier, it was always thought that surgery is much better, but here, TAVI is equal. All complication rates absolutely equal. Strokes slightly higher in surgery, and as I said, pacemakers are something which is definitely associated with TAVI. Now, the paravalvular leak or the aortic regurgitation, which we discussed, is definitely more in TAVI, but not the moderate or severe one. The moderate and severe leaks are associated with bad outcomes, but the mild leaks are not, and that is what is more common. Conduction abnormalities are seen, but the advantage is that these conduction abnormalities are getting better and better with better techniques and with newer devices. Whereas in surgery, these problems of bleeding, kidney injury, atrial fibrillation, cardiogenic shock, longer hospital stay, not to mention the morbidity associated with the surgery, these are staying steady. This is not changing with time, but TAVI is taking leaps and bounds ahead. And this trial concluded that even 5 years after TAVI, there is no difference in the mortality stroke as compared to surgery. There is no difference in the durability of the valves. In fact, the hemodynamics, the way the valve functions, the gradients are lesser than the surgical valves. And pacemaker rates, although high in some valves, are lesser with some other valves. This trial, to me, is a groundbreaking trial which we should sort of acknowledge. And this trial was the first trial which showed that even in the low-risk subsets, TAVI was superior to the surgery arm of the trial. And why is it shown superiority? Because it is shown that the morbidity associated with surgery, the hospitalization days, the strokes, all these things come into play when it comes to the overall outcome and to the overall patient benefit. So this trial has opened our eyes to say that look, there is a possibility that TAVI is even superior to surgery. And again, why is this important? Because in the surgical arm, the outcomes were excellent. This was done in centers of excellence. The death at 30 days was 1.1% in the surgical arm. Strokes were the meager 3%. But in spite of this, the TAVI was better. Now, this has to be taken into account because this study did have a large number of patients, and it's shown that TAVI is an option to be reckoned with. The TAVI has a lower rate of atrial fibrillation and hospitalization, whereas the surgical complications are, as we've discussed, always the same. Now, having said this, another trial has also given us the same outcome, the CORE-VALVE low-risk trial. So we are not talking about basing our opinion on one trial. We are talking about several things and several trials which have shown these kind of benefits to our patients. Now, based on this, the FDA, which is one of the hardest nuts to crack, has shown that all these TAVI valves, which are all available in India and which we are using the Evolut Pro and R, which we just spoken about in Dr. Ekmeta's presentation, these are now sanctioned in low-risk patients and should be used regularly. Now, coming to the second most important thing that we will all want to discuss about the cost of TAVR. TAVR costs are so important. How is someone supposed to spend this kind of money in our country? Now, we have to first understand that the cost of TAVR in the US is twice the cost that it is in India. It's still a gigantic amount of money to spend, and it still remains a big task for the government to support this program in the health sector. But we also know that India has a history of spending low amount of GDP on healthcare. And as you know, majority of the expenditure in our country is on by personal expense. Insurance companies, etc., account only for 5 to 10% of healthcare costs. Now, is it a challenge for every Indian, an average Indian, to support this kind of procedure from their pocket? And this is a study which answered that question. Now remember, this study was done in the US, where the average cost of TAVR is twice the cost in India. And what is this saying? That if you think of the lifetime costs associated with TAVR versus surgery, people in the long run end up spending close to $8,000 to $10,000 more after a surgical valve replacement. And TAVR has much lower costs and greater quality of life. And this is a slide explaining that the TAVR, because of the low hospitalization days, the lower rehospitalization rate, the lower follow-ups because of atrial fibrillation and those complications, you tend to save a huge amount of money at every stage, whether it's from your first 30 days all the way to the next 24 months. Now, so like I said, the cost and the expenses, we don't need to think of the short-term costs, we have to think of the long-term costs. The next question which always comes about is the device durability, and this is a few important slides which I've got from some physiology textbooks, and that is that, many patients, we are supposed to have an aortic valve area of 3 to 4 centimeters square, and that's when we can function optimally. But as we get aortic stenosis, the area goes below 2 centimeters square, and this is where the problem comes up. When we have surgical valves in place, these aortic valve areas tend to be below 2 centimeters square. And this is something called patient prosthesis mismatch, which can add to the long-term problems related to patients. So if you want to target an area of 2 centimeters square and above, here if a patient exercises and goes from this level of exercise to this level, when the area is about 2 centimeters square, their flow will increase. But once your valve area goes below 2 centimeters square, I'm talking about post-operatively or post-TAVI, then as the area goes down, the gradients will go up. And this is when patients get symptomatic and uncomfortable. And it's not true in younger patients, which is why we have to be very careful when we offer a younger patient a TAVI versus a surgery, because are we giving the patient the justice of a good valve area? And this slide gives us the answer. That when you compare surgical, the blue line, versus the aortic valve area, the yellow line, look at the difference in the valve areas. They look like very small numbers, 1.5, 1.9. But come back to the slide before, 1.5 and 1.9 is a big difference on this chart, this curve. Therefore, as you can see, the TAVR valves have better hemodynamics. This is something to be accounted for when we offer our patients the procedure of TAVR versus surgery. Coming to complications, our complication rates are, of course, like we discussed, getting lower and lower and lower. Smaller catheters, better devices, the complications, the stiffness of these catheters has become so much better as we've gone ahead. Strokes are going down and down. Of course, surgical procedures have higher stroke rates. Now there are embolization devices which are coming into the market which even prevent strokes and TAVIs. This slide shows us that the aortic regurgitation or paravalvular leak is majority, even in our study, a majority of our patients had no leak or a mild leak. There were no patients with severe and just about 2 patients who had a moderate leak. And those patients all fare well. Only those severe or moderately severe leaks don't fare well. But the device industry has added benefit to that as well. The newer devices have these skirts at the bottom, as you all can see. These skirts are designed only for one thing, to reduce the leak rates. And therefore, that's a great advantage because our device companies are getting more and more innovative. As is with the pacemaker rates, a lot of patients have, we predict and tell them, look, you will need a pacemaker because of their age. Older people are more prone to it. But again, certain devices, certain companies like Accurate Pneumo and the Sapien valves, these are supposed to have much lower pacemaker rates equal to the surgical pacemaker rates. We've spoken about valve durability, and this tells us that up to for 15 years and more, valves have shown to be they are shown to have a good durability, and the valve failure rates are much lower now. So these valves are known to produce long-term and good consistent results. Now the last thing we will discuss about is the peculiarities in Asians or Indians. Now we are known to have smaller valve areas, smaller arteries, more bicuspid valves, and these all add to the complications or the challenges we face during our procedures. Now having said this, if we have a smaller valve area and we are offering a surgical valve which, like I showed, has smaller valve areas after the surgery as compared to a TAVR valve, then we should be offering all Asians and Indians any kind of procedure which has a better hemodynamic result, and that is associated with TAVR. And the last thing which I am very proud to talk about is the team approach. Under the tutelage of Dr. A.V. Mehta, we have got such a wonderful team who works completely in synergy, and we are now performing what is called a minimalistic TAVR in the center. Conscious sedations, people are not put to sleep, local anesthesia, a normal 2D echo, not a transesophageal echo. Everything is done through the femorals, everything is closed on the table, no sutures go into the patient, he gets up and walks out of the cath lab if he wants. And the advantage is fast recovery. Our last 3 patients have gone home on the 3rd day, and very small procedure time, reduced costs. So to conclude, TAVR is already a refined, low-risk procedure with good evidence of intermediate to long durability. It's a procedure which should be used in low-risk and younger patients. Hemodynamics, which are so important in younger patients, are superior after TAVR. Complications are low and getting lower still. And the TAVR is the cherry on the cake. I will now keep a slide just for my surgeon friends, which is certain subsets will always be there for our surgeons, so they should not be in despair. But with that, I'd like to say thank you very much for the patient listening, and hand it back to our moderator.